Dr. Grabowski, I'm going to ask you a series of questions. I ask that maybe you reply quickly. Some of them I apologize if they've been asked earlier today. But you mentioned in your testimony care shifting out of institutions and into the home, and seniors want to be at home, which is no surprise, I think, to any of us. We need to ensure policies support that trend in a sound way, which is one of the reasons we're here today, ensuring appropriate access, quality care, and consistent health outcomes. You comment that there's adequate access to Medicare fee-for-service for home health agencies, but is it timely access, sir?
Yeah, this is such an important issue that supply does not equal access, that obviously we need better data behind are they getting timely visits as you suggest? And I don't know that we know that nationally right now. And that would be great if we could get such a data set.
Noted and appreciated. When a patient's been referred to home health, how long does it take for those services to begin, typically?
They should start relatively quickly, and that's actually a measure of quality, like timely initiation of care. So you'd hope within 48 hours.
Okay. Are hospitals able to routinely identify a home health agency for patients when they're ready for discharge?
Sometimes yes, sometimes no. It can vary. There are software where they can sort of give beneficiaries a roster of places, but
and who's measuring this quality outcome?
We know,
and rewarding it, presumably.
We have data on timely initiation of care, but we don't really know refusals. We don't really know the process that happens. That's all underneath the surface.
Okay. Are seniors or families reasonably able to find a home health agency with availability?
That once again can really vary by market, and yes, they can go on Home Health Compare and compare the star ratings, but they don't know if that particular home health agency is accepting patients at that time. So there's a lot of blurriness on the part of, I think, our patients and their family members.
Yes, and we're I think appropriately asking patients to be consumer-oriented, discerning shoppers. We need to empower them to do that, I think.
Absolutely.
Yes,
and to say very quickly, there's legislation that hospitals, I know not every home health patient comes through the hospital, but for those leaving the hospital, the Congress has put legislation in place that the hospitals should be helping them, but hospitals aren't always doing that, and hospitals don't want to play too heavy of a role in that, but they should be providing information to beneficiaries.
Okay, so we need to persuade them and incentivize them perhaps to comply with existing law. Right.
And by incentivize as well, Senator Whitehouse mentioned ACOs. That's a perfect example of an entity that's very incentivized to kind of worry about costs and placement. And there's, as was suggested earlier, there's been a lot of transition out of skilled nursing facilities to home health agencies when you incentivize hospitals under an accountable care organization or ACO.
Thank you, Doctor. Can you speak to the health outcomes for patients that utilize home health compared to those that do not?
No, there's absolutely a benefit to home health. My only sort of tweak, and I said this in my testimony, is that I wish we had better data, and I wish the assessment data were better that the agencies report, because I think oftentimes it's when you track over time, a lot of the claims-based measures that we think are more objective seem to be suggesting stagnant quality or even declining quality, where these agency-reported quality measures seem to be suggesting improvement. And I worry that we don't have a great set of quality measures here.
Sure. What data is missing to ensure patient access to quality home health services?
I think it goes back to a lot of those agency-reported measures, like physical functioning. Are they improving? Are they maintaining their physical functioning? So I don't know that we have a great accuracy with the current data that are being reported.
Okay, as you answered these questions, I see some real opportunities for us to tighten things up, so to speak. You caution Congress about making major changes to the patient-driven groupings model, PDGM, that payment system. Given this new system was adopted at the start of the pandemic. Based on the design of the payment model, what should we expect in terms of access under the PDGM?
Well, the PDGM, just to back up a little bit, really changed incentives pretty dramatically. Under the old payment system, home health agencies were paid based on the amount of therapy that they delivered. And so, as you can expect, when you pay for therapy, you get lots of therapy. Under the new system, they're paid based on patient characteristics. And so, we should see higher acuity patients being admitted into home health. That would be the expectation. I think it's a little early, given the pandemic, to really track what's happened under the PDGM. So I would just caution Congress about making changes until we're able to move out of the pandemic and really get a sense of how this policy is working.
And then as we come to a close here, I'm going to ask you a two-part question. How long will it take for researchers to, in your words, disentangle what changes are due to the PDGM rather, and what is due to the pandemic? So how long will it take for that? And do you feel there is the potential for access concerns as researchers and CMS navigate post-pandemic data?
So I think it'll take several years here. So I think it'll be over the next several years that we'll get a sense of how things are working. So the next 2 to 3 years when we begin to get data. I hope we're able to look at access. It's got to move, as you said, as you indicated with your very first question, it's got to move beyond supply and utilization-based measures and really look at timely visits, whether agencies are able to accept new patients, what types of patients are being admitted into home health.
Thank you, Doctor. Chairman?